Chapter 1, Healthcare. How did we get here and where are we going? By David M. Lawrence. Dr. Lawrence was CEO of Kaiser throughout the 1990s and opens the textbook here on the Handbook of Healthcare Delivery Systems. This opening chapter starts with the optimistic quotation from the Institute of Medicine that states, "Between the healthcare we have and the care we could lies not just a gap, but a chasm." And so right at the start of the text, Dr. Lawrence sets out a thesis for why we have poor delivery in contemporary healthcare and paints a future of how healthcare may be delivered in the future. And although I agree with his assessment of the situation, I actually suspect that most physicians would be quite angered and disagree with his analysis. And so the chapter starts with the usual openings, discussing the fact that the US healthcare system kind of sucks. We already all know the numbers, the fact that it's, quote, superb for some, but the costs are unsustainable, its quality and safety unpredictable, and the value it delivers markedly lower than that found in other developed countries. And so despite the fact that there are excellent clinicians working within the United States, patients continue to find the system a nightmare to navigate. It's impersonal, confusing, fragmented, and the poor design sets the workforce up to fail, regardless of how hard they try. And so, if a safer, higher quality healthcare system is what we're looking for, it needs to be redesigned. But why has it not been redesigned to date is the question Dr. Lawrence asks. Why is it that we continue to have the widespread practice of solo physician practices, which is essentially the same model that existed since World War II? And he says, most people will blame the payment systems. It has to do with the fee-for-service models. But Dr. Lawrence says the primary reason for the stagnation in improvement in healthcare delivery rests upon physician culture. And here, Dr. Lawrence will now build an argument for why physician culture, with its focus on physician autonomy, physician exceptionalism, and the preference for intuition, holds healthcare behind. Physician culture in the United States was developed in the 1930s after the formation of physician groups emerged out of that of quacks and charlatans. And this group of physicians would hold up and combine science, experience, and judgment in their profession. Physicians were trained skeptics of the work of others. They would gather their own information by carrying out independent assessments for each patient and prefer to work alone, surrounded by the support staff, interacting with patients on their own terms. Only when a physician reaches the limits of their largely self-defined competence or their tolerance for legal risk do they refer the patient to another doctor who repeats the same process. And this quotation was not describing physicians working in the 1930s, but physicians working today. In medical school, physicians are trained to prioritize autonomy as a core value, the ability to operate independently and to not have to rely upon others. In turn, there are few opportunities to learn concepts of shared decision-making or working in complex teams with other physicians in taking care of patients or with other health professionals. As an aside, some may suggest the work we do on the internal medicine wards is very much a team atmosphere, but I would actually posit that it is more a delegated hierarchy than a highly functioning horizontal team. And when there are multiple horizontal members involved in a particular patient's case, they function as autonomous units rather than a unified whole. And much of the work which takes place in the outpatient clinic does remain entirely isolated. There are only, in my opinion, very few physician groups which practice using the concepts of shared decision-making. From what I have seen, this is often in complex case rounds, for instance, in complex cardiology case rounds or in oncology case rounds, where groups of experts are brought together to analyze data as a group and debate the arguments of what the best course forward is. This is certainly the exception and not the norm in the clinical workflow of a physician. And this is supported by the fact that most physicians practice in single specialty groups of 10 or less, and over a third of physicians work alone. Dr. Lawrence also attributes to the concept of physician autonomy the fact that physician groups continuously work to limit the roles and competencies of other health professions. We see this time and time again when nurses, nurse practitioners, clinical assistants, pharmacists, or paramedics try to broaden the scope of their practice, typically actually to have the same practice which such professions have in other jurisdictions or other countries. And physician groups will often criticize the broadened scope of practice, suggesting that it will harm patients. And in the end, we're left with a situation where we have wide physician autonomy, and as a result, there is wide variation in practice style, and there is retaliation against calls for greater transparency or accountability in work or outcomes. Could you imagine how physicians would respond, for instance, if they were told that all colonoscopies had to be recorded in their entirety with a copy to the patient and the clinic, or that all surgeries had to be recorded in their entirety with a copy to the patient and the hospital? Physicians mock the introduction of guidelines or best practices or care pathways. Such concepts are viewed as cookbook medicine and something that is antithetical to the professional insights, clinical acumen, and personal touch of each physician who knows best how to manage the unique needs of their patient condition. And we are left in a situation where practicing with autonomy and minimal oversight is the norm, and this perpetuates a fragmented healthcare system. Dr. Lawrence pits this concept of physician culture against medical science, suggesting the two are actually antithetical to each other, which seems quite counterintuitive. Lawrence suggests that science is always trying to bring greater clarity, specificity, and accuracy to medical care. Science works to remove clinical ambiguity. It tries to categorize and diagnose, and to use data to move one away from intuition and the gray into more black and white. Ultimately, advances in biological sciences, social sciences, and communicative science, such as information technologies, will allow new models of care to flourish. And these new models, which rely on science and information technology, will allow non-physician caregivers to deliver high-quality, more reliable, less expensive care than current physician models. For instance, you could imagine how powerful a clinic run by wellness experts, nurse practitioners, and nurses and lifestyle coaches combined with a comprehensive electronic medical record that could automatically titrate a patient's diabetes medications, insulin, and antihypertensives could be, in comparison to a single physician who can see a patient twice a year for 6 minutes. Which leads into the next part of the article, which discusses the changing demographics and demand for healthcare. As the demand for acute medical care decreases and the prevalence of chronic comorbidities and chronic conditions increase, contemporary models of physician care are inadequately equipped to provide ongoing chronic disease management. Chronic disease management requires very integrated organizations that rely primarily on non-physician caregivers to work with patients in modifying and identifying their risk factors and managing chronic disease. Physicians are just simply not trained to be able to do this at scale, and the economic forces of these interactions don't work. And the chapter ends now with 4 battlefronts being proposed, where physician culture and outmoded physician-dominated delivery systems will come into conflict with new models of care. The first one is the reform of the sick care delivery system. This is essentially the reform of contemporary medicine, but the creation of integrated care practices such as Kaiser Permanente, Mayo Clinic, or Virginia Mason. And these integrated care practices will rely heavily on information technology and industrial engineering to drive performance. He goes on to point out that medicine seems to be the only industry in the world that is currently able to function at 1 or 2 sigma in normal operations, meaning that an error occurs in every 1 in 10 care interactions, or at best 1 in 100. This is in contrast to most high-performing companies that function at 6 sigma, meaning an error occurs every 1 or 2 in a million times. The second battlefront is the consumer health ecosystem. And here we have expansion in patient mobile monitoring and the expansion in distributed information systems, if you think of it as cell phones. This means that more services will be able to serve patients directly without the need to go through a physician office as the intermediary. And so the use of automated algorithms, information systems, and low-cost non-physician personnel will mean that care will become less expensive, more reliable, and not bound by the limited availability of physicians. Such systems could provide patients access to services and care 24/7, 365 days a year, and far more effectively be able to triage a patient than, for instance, a primary care office. The third battlefront is the new personalized medicine paradigm. It is suggested that with personalized medicine, there will be an ability to recognize illness before it produces symptoms and complications. And this has the potential to make the contemporary model of physician tools for diagnosis and therapy based off of the expression of phenotypic disease outdated and obsolete. And the fourth battlefront is the concept of accountable organizations. It still remains entirely to see how these will perform, who will control them, what will be the role of physician leadership within them, and how conflicts between clinicians and managers will be resolved. And the chapter ends with the final thoughts that the sick care system has become a collection of complex production processes, but efforts to improve performance have largely failed because of the overriding need to preserve an obsolete organizational model. The application of tools of industrial design can help change this. And that's chapter 1. It sets the stage that healthcare has a lot to learn from other industries, and that perhaps one of the reasons healthcare hasn't progressed like other industries in improving the quality of its service or availability or driving down the costs is the fact that physicians are seen as the core of healthcare. But in the future, they may not be.